So I'll be basically sharing my views on GDD implantation in different situations. So I'm not showing you the normal implant surgery, but I think the steps will be, kind of a demonstrated there. So we already know the complex situations. I think that Uvi has already mentioned where we need to put the implant. So I'm not going in details of these. So I'll go straight with the situation. Now, this is a 50 years old lady, and she had 6/9 vision, but the IOP is 40 millimeters of mercury with everything on systemic carbonic anhydrase inhibitors. And there's a staphyloma there. You can see the patient had a scleritis. So there's no way you can do a trabeculectomy there. Now, important thing is here is that behind this staphyloma, there's a normal sclera, and one can possibly put an implant there. So in the superior temporal quadrant, you can see there's a healthy sclera behind the staphyloma, about 8, 9, 10 millimeters from the limbus. So you find the sclera. I usually prefer to put a pre-placed sutures, and after priming the AGV implant, this is the AGV implant. So after priming the implant, you just suture the implant to the sclera there, like you do, in any other situation. I like to use a, the Dacron suture or Ethibond suture, which is 5-0 or 6-0. Uh, the reason is the needle is good. This is a side cutting, the spatulated needle, which has a less risk of scleral perforation. So I like to use that suture. Now again, here you have to go very carefully because this tissue can cheese wire very easily. So make a long track. I try to curve it a little bit to get it a longer, a little more resistant tunnel. And here you have to go in one go. Frequent to and fro movement of needle will create multiple tracks and will be hard. And this definitely needed to be patched up with a preserved sclera from the eye bank. And once this is done, the pressure was well controlled in this patient without any medication for the next 1 year. After that, she did need some anti-glaucoma. The important thing is the underlying pathology has to be considered because the uveitis can come back again. And so in the perioperative period, they have to be monitored for the underlying pathology. And for that, you might have to talk to the person to the uveitis person. This is another patient who had his uh, high myopia, had a retinal detachment, 26 years old, a young male, and had a silicone oil which was removed. So how do we do here? Because here you have a buckle is there. There's a band actually, so it's not a the pad buckle is a silicone band, and sometimes it's very hard to dissect, uh, this area. But here you could expose one of the quadrants, and here I'm passing the sutures, and I'm actually going through the band itself because it's lying somewhere there. And there was enough tissue was mobilized enough where we could put an implant. But again, the cost consideration is an issue. Otherwise, I might have opted for a AGV because that would have been much easier. But you have to also look at the patient affordability. And so if there's a band, you can go behind the band so that this is uh, this implant is actually going behind the band and suture to the band more or less, and to the underlying tissue, because this is a non-valve device, so it has to be, this tube has to be ligated. That has to be kept in mind. And again, uh, with a long needle tunnel, you could put the tube into the anterior chamber, and that's how I was dealt with. This is another 40 years old male patient. This I did long time ago when Adi was not available. And I specially procured a Barwell implant for this. This is Barwell 250. He had a very high buckle, but we didn't have any option at that time. Again, very poor patient, couldn't afford AGV. So I had no option but to do that extensive dissection. And the tissue was very scarred already. So I had to go all the way behind the buckle. There's a bit of risk of going on right to the optic nerve, but I think we were okay here. So because to avoid I actually cut the buckle and threaded the tube under that because I didn't want a lot of bulge in that area because of the overlying tissue was not very healthy. In this case, I put sutured, occluded the tube using a stent suture. The idea is that because this patient had high pressures, and if the pressure really goes out of control following this surgery or in the while the suture lysis happens, one can always pull out this stent suture and release the pressure prematurely, though there is a risk of inducing a hypotonia at that stage, but sometimes you might have to do that. So here, because the anterior segment is very distorted, so the tube was put posteriorly, and again, like put a skilled patch graft, and then you covered the conjunctiva on top of it. This is how this patient looks like. So 10 years later, you can see the anterior segment is still, the cornea is still clear. Everything is, damaged. Iris is, tissues all damaged and stuck to the back of the cornea, but you can see the tube behind the cornea, and that area where the tube is, the tube is slightly visible, but the tissue is holding on very well. And the patient has a 360 vision with 18 to 20 millimeters of pressure with 2 anti-glaucoma drugs 10 years later. He's still, that's the only eye this patient actually, in, when he had a motor vehicle accident, the other eye was lost at that time. So this patient has been mobile, independent for 10 years after this procedure. So question is how well GDDs do in glaucoma following pars plana vitrectomy. And this is our own experience. 78 as a 78 patient where we did with GDD, where AGV was put, and they had trauma, regiment detachment, and other issues where vitrectomy was required, and on an average follow-up of 70 months. So we could see the pressure was well controlled in majority of these eyes. And the cumulative probability of success was like 92% at 2 years and 80% at 5 years. So that's actually very, very gratifying results with these tubes. So sometime when nothing works, I think these patients, of course, this is a qualified success. That means many of them would be on multiple drugs. So that is also there. And so you can see that there's significant reduction in the IOP as well, anti-glaucoma medicine in this group. But eventually after 2 years or 3 years, most of them, there's an increase in the number of anti-glaucoma medicine, which is required to control the pressures in our 2 years, beyond 2 years. But still is a very good result, giving the, looking at the situation that that we are. The other thing is, sometime if there's a very big implant, the other procedure you can do is you can put a shocker-like implant. So this is not a shocker implant, but some on similar concept basically. So what you do is you just open the conjunctiva carefully with this. You can see there's a lot of scarring. There's a big buccal there, and there's a very good capsule around the buccal. So when you dissect carefully as not to destroy the buccal. And this is a silicone tube with the size of the normal 0.6 millimeter outer diameter and about 3 millimeter internal diameter, and 0.3 millimeter. And you can see we can just with a needle create an opening there and put some viscoelastic into that space to expand it, and just thread that needle which we have made, and just push it as much as you can, and anchor this needle, this silicone tube to the sclera. So it becomes a socket-like implant basically. You're using the existing buccal and the capsule around that buccal for your advantage, and just put this tube into the anterior chamber like you do for any implant. Now in this case, I use Vicryl actually to fix a tube, but now I use non-absorbable suture because Vicryl can get absorbed and there could be late displacement of the tube. So this is the same patient who looks, you can see the tube is very well placed. This is after 3 weeks surgery. The other thing is the difference, which is the post-penetrating keratoplastic glaucoma, and these patients also, they tend to do poorly after routine surgery. So in this case, again, the surgery is like any other implant. So go expose one of the quadrants, and you can prime the valve. Here you could put a tube, or you could put a AGV, or you could put an RD implant like valve or non-valve. It's your choice. I think both will do equally well. So whatever, so you have to look at the pre-operative IOP and how desperate you are to, get the IOP control, how quickly you want the IOP control, and that could decide which implant you want. So procedure is basically similar to what we did earlier. So, and again, we had a series of these post-penetrating keratoplasty eyes, which we have published some time ago. And here again, we have used RD as well as AG implant in post-penetrating keratoplasty eyes. And results is more or similar. So it doesn't, as far as IUP control is concerned, there's no difference between the AGB valved or non-valved device in our series. And as you can see, the IUP control is almost similar over a period of time, but this is a short-term follow-up only. So I think what happens later, we don't know. So thank you very much. I think these were the basically, some of the cases that I want to show you in some of the situations where we might have difficulty in putting in a implant, but they do very well, with this kind of implants. Any other surgery would have been impossible in these situations.